Okay, guys, ready? Ready to jump in? Before we do this one, any questions about cardiogenic shock? You guys solid with cardiogenic shock? Yeah? Okay. So, next patient. Patient has a history of drinking a bottle of vodka a day. Sounds like an expensive habit. Patient complains of abdominal pain and reports having liquid maroon stools. Patient feels nauseous, it should say nauseous, not nausea, but whatever, and had an episode of emesis during interview. Emesis approximately 300 mLs of bright red blood. That's not good. Vital signs 145 heart rate, high, low, or normal? High. Very high, right? Blood pressure 73/40 with a map of 50. Low. Very low, right? That map of 50 we do not like. Respiratory of 35. High, perfect. Thank you, Scarlett, for participating. Temp of 36 degrees. Normothermic, right? And then O2 sat of 87% on room air. Okay, so a little hypoxic. Okay, so given this patient's presentation, what is your game plan? Name that shock and what are you going to do about it? What do you think is going on?
It's like the liver thing that you say, that they're not populated.
Oh wait, how many keys?
The liver.
Cirrhosis. Or burns. Sometimes.
Alright guys, let's talk about this. So, second type of shock that we're going to talk about is, I named it, hypovolemic shock, right? And I got it, don't worry. Okay. So hypovolemic, goodness gracious. This one sucks. Let's try a different one. Maybe purple. Maybe purple is going to be here. Okay, so hypovolemic shock, right? So you have basically a cup. This is a fun little mug, okay? And it's low. The volume is low, okay? So there can be internal or external causes, okay? So what do we think an internal cause is? Okay, so internal would be like third spacing. Like there's, the fluid is going where it's not supposed to, okay? External is what I heard everybody just say, bleeding, okay? So hemorrhage. That's kind of what we're looking at for that guy, right? Okay. So besides bleeding, usually that's the number one thing. Okay, yes.
Would a pneumo be considered internal?
For hypovolemic?
Yeah.
No. That might cause cardiogenic shock. For like a tension pneumo.
Yeah.
Yeah. But I don't think it would necessarily be hypovolemic because you're not losing volume anywhere. Okay. Okay, so hemorrhage, bleeding, that's the key. I also heard someone say it earlier. We live in Phoenix. It's September, it's still 500 degrees outside. What would be another cause of external hypovolemic shock? Dehydration, right, exactly. So, oh my gosh, this pen, I'm over this. Okay, dehydration. Okay, what else? What could also cause hypovolemic shock? Trauma, sure, but that's probably going to cause bleeding, right? Burns, yes, absolutely, I love it. So there's lots of fluid loss when we talk about burns. Okay. What about our favorite endocrine disturbances? What do you guys think? DKA, love it, right? Can that cause hypovolemic shock? Yeah. DKA, or even, what's the other one that I love? GI, yep, totally, love it. So anytime you have lots of loss of fluid, okay, loss of fluid. Someone that's even having, you know, you have the stomach flu, that can lead to hypovolemic, right? Because it's coming out both ends, right? GI losses, you're throwing up, also having lots of stool, okay, that can cause hypovolemic shock. So again, we're talking about this guy, right? He's the one that drinks a vodka a day. By looking at this, if we had to just throw out the cause, what do we think the cause is? For this hypovolemic shock. What do you think is wrong with him? Why is he bleeding? Okay, so maybe GI varices. Love it, right? We know if someone is drinking a bottle of vodka a day, they clearly have some sort of habit that's happening, right? So if he has ETOH abuse, we know that he's going to be at higher risk for GI bleed at baseline. And then we know that if he's drinking a bottle of vodka a day, his liver's probably going to be impaired. You just throw that out there that could be the case. Even if he hasn't been diagnosed, it could be the case, which could lead to esophageal or gastric varices. Absolutely. So irregardless, we know because he has emesis of 300 mLs of bright red blood, that's a lot. Okay, that's a lot. And then he's also having liquid maroon stools. So it's taken the time to go through his GI tract and he's stooling old blood, essentially, that we know that he has some sort of GI bleed. Okay, right? Some sort of GI bleed. So in looking at this, we've identified hypovolemic shock. What are we going to do about it? Okay, so, Okay, so I see fluids. That's great. I love it. What kind of fluids do you want? Okay, I mean, sure, maybe albumin initially. What else? What'd you say? Isotonic. Okay, perfect. So, isotonic. What type of fluids are isotonic? LR or? Normal saline. Okay, so let's say that you grab a lab. In this instance, what would be a lab at the top of your list that you would want to get? H&H or CBC, right? I would anticipate that if this guy's throwing up blood, right, that the H&H would be what? Low, okay. So we talked about isotonic fluids. Love that. I think that's great. But I just slammed in 2 liters. What is that going to do to his hemoglobin? So let's say his hemoglobin's 5 and hematocrit's 19. And I just gave him 2 liters of isotonic fluid. What is that going to do to it? It's going to dilute it even more. Okay? I'm not saying it's not wrong. I'm not saying it's wrong. I just know that if I'm giving fluids, it could be a start to fill that tank with isotonic, but I know that I'm gonna need blood. Blood's gonna be very important, right? So with this hypovolemic shock, we know that the issue is bleeding. Okay, now, anybody know how long a type and cross takes? If you send like a type and screen down to the lab, how long does it take for them to process it? At least an hour, I would say. Even though you could be calling, like me, and I call a lot, and I'm like, hi, we have this patient that's bleeding out, we need blood right away. Okay, what could I give them if I didn't have time for a type and screen, or excuse me, type and cross? ONEG. Okay, so I could do ONEG. So again, he lands up to your unit, I see that blood pressure, I'm hanging a bag of liter. In my mind, I know that I'm glad I'm hanging that liter because ultimately the tank is empty. Okay, the tank is empty. So remember, if we look at our thing, again, the delivery is being hindered, okay? When we talk about cardiac output, the stroke volume, I got none. There's no volume in there, okay? The tank is low or empty. So I need to fill it up. So I know I can hang that liter of NS or LR, but I know that I'm gonna need some blood. Does that make sense? Okay. So I know that I'm gonna hang some ONEG while we are getting the type and screen because I don't have time for that. This patient doesn't have time for that. Okay, now the patient, we're slamming some fluids in. Would I possibly need to warm the blood?
Yes.
Why? Why in this particular instance would it be important to warm the blood?
You're trying to get it in there fast.
Okay, so sure, you want to give it in fast, okay. You don't want to cause hypothermia. Why?
Because it'll throw them into a different type of shock.
Because what?
It'll throw them into a completely different type of shock.
What kind of shock is that? So I mean, I think you're on the right track. But when someone's hypothermic, it causes them to bleed more. We don't want people, especially when they are in hemorrhagic shock, we don't want them to bleed more, right? When you have someone that's hypothermic, their coags don't work properly, lots of issues, okay? So when we get to trauma, we have to warm all of the trauma patients up because a lot of them are coming in with hemorrhagic shock, okay? So if you're getting large volumes of blood, you absolutely should be thinking to yourself, I need to warm this, okay? I need to warm this. I need to be thinking that I'm gonna be getting what type of blood? ONEG, okay. Now we've typed and crossed it, and now we have like his type of blood, let's say A positive. Okay, so what type of blood? We talked a little bit about this a couple times ago. What'd you say?
Packed red blood cells.
Okay, packed red blood cells. Okay, so we anticipate that we are going to be giving him to fill the tank PRBCs, right? Packed red blood cells. But I also know that if I'm giving him 4 packed red blood cells, I need to also give him what else? Platelets. Okay, great. So let's say at least a unit of platelets. What else?
Plasma.
Plasma, yes. FFP, fresh frozen plasma. So anytime you do large volume of PRBCs, know that you also are going to have to give platelets. You also are going to have to give FFP, right? Because if you're giving, just like giving a lot of fluid, right? You're going to dilute anything that you're not giving. Does that make sense? Okay, and then you could also possibly give cryoprecipitate, okay, which is going to help that clotting. It's more clotting factors, okay? So how am I going to give it? What do you think? How am I going to give this blood? Am I just going to lay the pack on him and hope for the best and think that it's going to be osmosis into his chest?
Just drop it into CT2.
Right. Be rough. Be a lot of aspiration. Okay, so I heard central line. Okay, possibly. But what do you think would be better than a central line? Okay, so let's say 2 large bore IVs. 2 large bore IVs. Okay. So when I say large bore, what does that mean? Does that mean 22? Is that a large bore?
18 or larger.
18 or larger. How about a 16? How about a 14? 14's huge. But again, larger bore, right? We want to make sure that we can give lots of fluid. Yes, a central line, sure, I take what I can get, but I can give more volume faster with a larger bore IV. So when you see someone in hypovolemic shock, you need to be thinking your priority is to get fluid in. In order to give that fluid, I need 2 large bore IVs at least, okay? I know that in this this game plan, right, that I'm gonna be warming the fluid because I don't want him to become hypothermic, okay? And then in this particular instance, okay, I'm giving him, I gave him a bag of NS, he's getting his 4 PRBCs, his 2 FFP, his platelets, his 10 pack of cryo. But again, I'm filling the tank. What do I need to do to fix the bleed though?
Find the cause.
Okay, so find the cause. How am I gonna do that? What do you think? What do you anticipate to do? An endoscopy. Okay, so we need to scope. We need to invite GI to the party and say, hey, we need to figure this out. Because again, we can fill it up, right? We can fill up our tank, but if he's still bleeding and hemorrhaging, is it gonna go right back down? You better believe it, right? You better believe it. So we know that we can fill the tank, but essentially you need to fix the problem, okay? Fix the problem. So something to make note of with hypovolemic shock is that you will see someone become, very tachycardic, okay? And then interestingly enough, when someone is in hypovolemic shock, you'll notice that their pulse pressure is going to be very narrow. Professor Bloor, you're saying words I don't know. What is pulse pressure?
Is it like systolic minus diastolic?
Totally, yes, absolutely, great. So your systolic and diastolic will get very close together. You're going to be hypotensive, but you're going to get, those numbers are gonna get very, very close, okay? Like, let's say 80 over 70. 70 over 50. So it's going to become very, very narrow, okay? That's another clue that you can see that you are dealing with hypovolemic shock, okay? So we know that we need 2 large bore IVs. We're giving all the fluid, okay? We know that we're going to warm the fluid. Now, when you give lots of blood products, right, and they come up from blood bank, now, how does it work that they don't come up as a big clot and you have to like slice and dice it and somehow give it to your patient? What do you think's in the blood? Okay, so an anticoagulant. Anybody know what it is? Close, but no, you're thinking. It's citrate. So they have citrate in the blood, which makes it, because you can think about it, right? Has anybody left like a tube of blood on the table? It takes like, I don't know, 10 minutes or so depending, and it will start to separate, it will clot, right? And again, why we have these bags of blood not clotting, not some big mass that you have, this blood clot, is because it has citrate in it. Citrate binds to calcium, okay? Citrate binds to calcium. So we know that if you're giving large volumes of blood, you would anticipate that your calcium is going to also be low. Well, Professor Bloor, who cares? Why are you talking about calcium? We're talking about blood. This person doesn't have anything in their tank. Okay, so if we think about the electrolyte calcium, right? I know, you're like, I hate electrolytes. She keeps talking about them. Why does that matter? Well, it matters a lot, okay? So if you think about calcium, right, it's an important vascular electrolyte. What do I mean by that? Well, let's make it make sense, right? What's narcotapine? What's cardine? What type of antihypertensive is that? Calcium channel blocker, right? That's a vasodilator. That's going to make your vasculature wider, okay? So the electrolyte of calcium helps vasoconstriction, okay? When someone is hypotensive and in shock, should we want their vasculature to vasoconstrict? You better believe it, right? Because we're hypotensive. So think about it. If you have low calcium, do you think that's going to contribute to your vasculature being even more dilated? Yes. So you need calcium. So if you anticipate giving a lot of blood products, this is pro tip, you guys, in clinical, people are gonna be like, whoa, they're so smart. You know that anytime you give large volumes of blood, you best be checking an ionized calcium and giving them calcium, either calcium gluconate or calcium chloride, okay?
What is the thing that binds to calcium?
Citrate. Citrate and calcium bind, and then that lowers your calcium in your body, okay? So we're warming it, we're giving fluid, okay, they get their endoscopy, okay, great, we're heading in the right direction. How do I know that he's fixed? How do I know?
When blood pressure normalizes and his heart rate goes down.
Okay, be careful with that. I think you're right on the right track, but I think that we need more objective data than that. Okay, so if you know that you have resuscitated someone fluid-wise, okay, what do you want to look for in their assessment? What do you think? Urine output, yes. Okay, so he probably has no urine output, probably for a while because his tank is empty. So how do you know the shock has gotten better? Urine output. He's fluid resuscitating. Okay, urine output. What do you think if we had a central line and a CVP? What do you think a CVP would be? Oh my gosh, you're talking about things. We took that test. We don't need to talk about that, right? If you fluid resuscitated him, what should your number on your CVP be?
2 to 8.
It should be normal. It probably should be on the more higher side of normal. 8, okay? It should be 8. It should not be 1 or 2. It should not be low or low side of normal. It should be 8, okay? So yes, you did say Scarlett. Sorry, I wanted to make sure. MAP will be improved. Your MAP will no longer be 50 or 40 or whatever it was. Your MAP will be improved. Your urine output will be improved. And then how about when we talk about cellular metabolism, what would their brain be doing? Is their brain getting delivery of oxygen? Right? If you filled your tank, you fixed the problem, you fixed the shock, we should not be altered anymore, right? So our level of consciousness will be improved. So how will the patient present if their level of consciousness has improved?
Awake and arousable.
Yes, awake and alert. They're oriented, right? You go in and you say, hey, Mr. Smith, and he said, hey, what's up? Can I get some Jell-O, right? Always the Jell-O. And you're like, no, you just had a GI bleed. You cannot have any Jell-O right now, okay? Or he asked for his vodka. Definitely not, right? So again, you have to be thinking, make it make sense. How do I know I fixed it? Urine output, okay? MAP is improved. Urine output, MAP is improved, and LOC. LOC is improved. Those are the 3 things you're looking at to make sure. Okay, why? Because,
General or just with,
what do you say?
is that specific to hypothalamic shock or just
All shocks.
general shock?
In general shock, yeah, in general. How do you know you fixed it? Urine output, right? And again, right, if you think about it, right? In progressive shock, you had everything going wrong. All your organs are failing, right? So if you think about the symptomology, you're altered. You're not making any urine, right? Your MAP sucks, it's low. Well, how do I know I fixed it? Well, it's better, right? It's better. MAP is better. LOC is improved, level of consciousness. They're awake, alert. They're talking to you. They want their Jell-O or vodka, right? And then their urine output has improved, right? So again, how do I know that I filled the tank and we fixed the problem? Does that make sense? Yes? Questions? Yes.
I just have a question, because in the book,
Yeah.
it says that internal includes hemorrhage and burns.
Yeah, I know. I mean, that's fine. I'm not going to ask you the difference between internal and external, but I just need you to understand that there's different causes. There's
Okay.
different internal and external. I think the external, why I want you to think about external for bleeding, well, I guess it could be both, but we're talking about him like throwing up and it coming out, right? And so I think it could be thought of as both.
Okay.
Yeah. Okay. Questions about this? No? What lab would I want to maybe recheck when I'm done with all this? What labs? H&H? Okay, what else? Or CBC maybe? Okay, what else? CMP? Okay, cool, to make sure all my electrolytes are stellar. Okay, I like it, love it. And what?
BNP.
Okay, BNP for heart are you talking about like to check their heart? Sure, I'm down. Let's see. Let's see if we affected their heart. Absolutely. Because again, if it's going to be high, we can say that the heart was hurt in this process.
Your heart was starved of fluid for so long, who knows if it messed things up.
Sure, it could be. Absolutely. Yeah, it could be. Okay. Questions about this? No? Okay, let's do some questions about it. All right, let's talk about it, yeah? So we have a 35-year-old male arrives to the emergency room with multiple long bone fractures and an internal abdominal injury. The patient is anxious. Patient's vital signs are blood pressure 70/54, heart rate of 125, respirations of 30, O2 sat on 2 liters nasal cannula at 96%. Temp is 99.3 Fahrenheit, and then we got to pay him because he's broken, right? He's got lots of broken bones. During assessment, it is noted the skin is cool and clammy. The nurse will make it a priority to what? So I'm hoping and praying that everyone established 2 large bore IV, right? Obviously, all the other things, they are important, right? They are important. He's 99.3, so he's not necessarily cold, so placing a warm blanket on him isn't, of course, your key right now. He's a trauma patient, so we're going to take all of his clothes and expose them to the environment very soon to check for other injuries. But that's not your priority, right? We know in what happened. He's a trauma patient. We know he has multiple long bone fractures and an internal abdominal injury. So mechanisms of injury, when we get to trauma, we're going to talk about that. But we can have a high suspicion that he is going to be bleeding. Long bone fractures equal hemorrhage, okay? Now, if that wasn't enough, we didn't have this history, right? We can look at the symptomology, what his vital signs are doing, right? We are tachycardic, 125. That's high, right? We have a low blood pressure, 70/54, with kind of a narrowed pulse pressure, right? And then respirators are high, okay? So we know that we can think that he's in hypovolemic shock. In order to give him fluid to fill your tank, you need 2 large bore IV. 16, 18, even 14 would be fabulous, okay? Yes, you're gonna do all these other things, but this is your priority, okay? Questions about that? Nope. Cool. Okay, great. Patient is in hypovolemic shock, is receiving rapid infusions of crystalloid. So we're 999, all those fluids. Which patient finding requires immediate nursing action? Okay, so expected versus unexpected. That's how you can think about these questions, okay? If someone is in hypovolemic shock, is it expected that they could have a heart rate of 115? Absolutely, okay? Is it expected that they could be anxious? You better believe it, right? Anxious, restless, those are some of the things that you could see your patient because again, they are in shock, they're not getting that O2 delivery, right, at the cellular level. Urine output is 35. It's great. What more could we want, right? Probably a little bit lower, but again, we're fine. Is it expected that the patient experiences dyspnea and crackles in the fields? Absolutely not, okay? So we're slamming the fluid in. Alex alluded to it. Maybe something happened where the heart was ischemic. There was some sort of ischemic, and now we have a mixed shock picture where the heart can't pump effectively, okay? It happens all the time, okay? Oftentimes it's usually septic and cardiogenic, but it could be hypovolemic. We don't know, right? So again, this is not expected. You should not have your patient having pulmonary edema when you're slamming fluids in and filling the tank, okay? So that's our answer. Okay, so septic shock, my favorite shock ever to talk about. We love septic, okay? So take a couple minutes and think about how will your patient present? What are the signs and symptoms you're going to be looking for? And then think SIRS. SIRS can actually happen in any of these shocks, to be honest. Systemic inflammatory response, right? It can happen anytime, but oftentimes when we're talking about septic, those are our first clue that something's wrong. Can I erase this part, this one? Is that okay? Can I erase this general umbrella shock, or you still want it up there? You got it? Can I erase it or no? Yeah? Okay, I'm gonna erase it.
Say with your whole heart, bro.
Okay.
Make a decision, go.
Whoops, so sorry. My bad. Apologies.
I had some.
Sorry. Okay, so let's talk about, you guys are doing great. You have a lot of the signs and symptoms, okay? So let's talk about SIRS really quick. SIRS can happen in any shock, okay? This is where you, in the ED, med-surg, progressive care, this is where you are gonna start to notice those little changes in vital signs, right? So what are some of the things that vital signs changes? I see it, some of them up there. So a change in temperature, right? So a fever. So we'll just put fever here. What about a white count? So if you're looking at SIRS, tell me what SIRS, when you look at SIRS, what kinds of things are you finding when you see SIRS? Fever.
Heart rate more than 90.
Okay, so heart rate greater than 90. Okay. What else?
Respiratory more than 20.
Respirations more than 20. Okay.
And white blood cells more than 12,000.
So greater than 12. Okay. Is that it?
Alright.
Okay. So, and then sometimes the fever, right? So I think it's greater than like what 38 or something. 38.
38.
What is it?
38 sounds cool.
Okay.
Or less than 36. It can be
Or
hypothermia.
less than 36. So hypothermia. Okay. What types of patients will not present with a fever? Everybody know?
I know.
Huh? Geriatrics. Geriatrics, oftentimes when they have any sort of SIRS going on or infection, they're not going to be febrile. Okay, just know that. Geriatrics, they're going to probably be less than 36. Okay, so if you look at this, right? Look at these vital sign changes. Okay, respiratory greater than 20, heart rate greater than 90. What other types of patients can have those alterations in vital signs? Don't look at the white count, but just think about it. There are some types that people that could have a heart rate greater than 20 and respiratory greater than 20. Heart rate greater than 90, respiratory greater than 20. What do you think?
Asthma.
Asthma. Okay, great. What else? COPD. Okay, great. We're on the respiratory train. I like it. What about someone that's in pain? What about someone that's DTing?
Anxiety.
Right? Anxiety. So what I'm trying to get at, you guys, is that a lot of people are going to have these vital sign alterations. It's important to take into the whole gamut, the whole picture. Okay? So do they have a fever, or are they hypothermic? Okay, are they lower? They're 35, for example. And then what is their white count? Okay? So again, when you have high suspicion, these seem pretty straightforward. Anybody can have SIRS, right? But we need to look at the greater picture and see what's going on. Interestingly enough, any patient in the hospital is at risk for developing SIRS and then subsequently sepsis. Why? Why is any patient in the hospital susceptible to that?
Invasive lines and around sick people.
Yes, invasive lines. Whether that's an IV, or maybe they have a central line, or maybe they have a Foley catheter. Okay, so everybody is susceptible to this. Okay, so now we do SIRS. Okay, then we look at what sepsis is. What's the criteria for sepsis? What about this table? I haven't called on you guys in a while. What's the definition of sepsis? What's the criteria that tells me I have someone that is in sepsis now? Okay, so SIRS plus an infection, right? Okay, so SIRS plus an infection. Now you said it's bacterial, but what kind of infection can it be? So you said infection, so bacterial. What else could it be? Viral, okay. What else? Fungal, okay. So SIRS, so we have these changes in vital signs plus an infection, okay? Now, what about severe sepsis? Wait, what is it? Sepsis plus an organ dysfunction. I spelled that right. Okay, so what does that mean, organ dysfunction? Give me some examples. What'd you say? Renal, okay. So how would I know renal? What's happening to show me that I have renal dysfunction? What? Okay. No urine. Love it. And increase creatinine and BUN. Okay, love it. Okay, what's how would I know that I have pulmonary failure? Lungs are involved. What do you think? Okay. We're just gonna put SOB. And then maybe even failure, like they're on a ventilator, huh? Okay. So again, here's an example of we have some sort of organ dysfunction. Okay. Now, shoot, I'm running out of line. It's okay. We got this. Severe sepsis. Now, what's the last one? Septic shock. Yeah. How do I know we're in septic shock? What's the criteria? Okay, so everything up to here, right? So sepsis plus organ dysfunction plus what?
Like blood pressure consistently being down, even though you keep trying to
I love it. So BP despite what? So hypotensive despite what? Fluid. So I filled the tank, but I'm still hypotensive, okay? So that is what we are dealing with, is that we've progressed to septic shock, okay? So you need to understand this algorithm of what happens, how someone can start with a very harmless SIRS, anybody can do that, people with pancreatitis, burns, pain, they present like this, okay? This is where we need to be thinking and stopping and being like, what's going on? Okay, because now when we get to sepsis, we have SIRS plus an infection, whatever that is, bacterial, viral, or fungal. Okay, severe sepsis is where we are now seeing organ dysfunction. Okay, it could be anything or it could be multiple things, but one organ at least is not functioning properly. Okay, and then when they get upgraded to the ICU, is that we have sepsis. So we have that known infection plus the organ dysfunction. We filled the tank and we still are hypotensive. Okay, does that make sense? So again, you guys named it. You have all of these things. We have, sure, we could have a fever if they're geriatric, maybe they don't have a fever. They're tachycardic, okay? We are going to have increased lactic acid. Mental status is going to be altered. Okay, now when we've progressed to septic shock, we know that we have multiple organs not working, right? So remember that head to toe assessment we talked about? We're there, okay? We're there where you're altered, you're going to be tachycardic, you're going to be hypotensive despite fluid administration, okay? You are probably going to be on a ventilator, right? You're going to be tachypnic. You are heading towards having that metabolic acidosis. Your lactic is going to be high, okay? You are going to be oliguric to anuric. Your creatinine is going to be elevated. Your BUN is going to be elevated. Your liver enzymes are going to be high because you're going to have shocky liver. So all those organs are going to be involved, okay? And then we know that despite filling the tank, we are still hypotensive. So you've given all of the fluid, but we're still hypotensive, so we're going to have to do what? Just leave them and hope for the best? Sorry, sir, you're in septic shock. What are we gonna do? Vasopressors. Excellent, so we need to do something, right? Vasopressors. I'm kind of skipping ahead, to be honest. So we've identified how they're going to present. Now we are going to talk management, okay? Goals of care, nursing interventions. So we know how they're going to present. We're in septic shock. What are you going to do? Please include fluid administration. Please include how much you think you're going to do. It's not a guess. There's a calculation that is associated with it. Okay? what labs do you want to do? What drugs can you anticipate? Okay. How do I know what drugs to give? How much fluid am I giving? And everything in septic shock is time sensitive. Time sensitive. We are under the gun with time sensitive. Just like heart is muscle, septic shock, you would say like life is time. In order to solve this, you want to do this in a timely fashion so the patient doesn't die. Okay? Is anybody using these computers? Can I lock this so I don't forget? You okay? Do you need it?
No,
Okay.
not right now.
Thank you. Anybody else? I just don't want to forget to lock it and get in trouble. Nobody wants that. Wow, that was way harder than I expected. Okay. Okay, so what are we gonna do for this patient that's in septic shock? All the time, this happens. Okay. Catecholamines, norepinephrine, and dopamine. Okay. Guys, I don't like dopamine. Why are you choosing that? It's okay. Sometimes people like dopamine. It's fine. Maybe you do. It's fine. You just got to make sure that your patient's bradycardic. You can't give someone dopamine that is tachycardic. Okay. Okay. So things are time sensitive. I see. Oh, thank goodness. Okay. So we see blood cultures. We see lactic acid. So I love that you put all of those labs up there, and I think that's so important. But when we're dealing with septic shock, sepsis, really, we hope we caught it in the sepsis range. We want to be doing this within 3 hours. 3 hours, time sensitive, okay? So within 3 hours, once you've identified, hopefully we're not in septic shock, but maybe you are, you want to make sure that you are obtaining a lactic level. You want to be maintaining or getting a lactic level to see where we're at, okay? You are obtaining blood cultures prior to antibiotic administration. Let me say that again. You're getting 2 sets at least of blood cultures prior to antibiotic administration, okay? And then once you get those blood cultures, you are giving broad spectrum antibiotics, okay? Why is that so important to do that in a timely fashion? Well, Professor Blue, I had to go to lunch. I had to go to lunch, my other patient needed their Jell-O, and like I didn't get to it and it was 2 hours late. Whoops. Why is antibiotics so important for this?
That's the source.
That's the source, yes. We know that there's an infection, you guys. We have, sorry, I'm so close to you. We have an infection going on, okay? What is going to be able to treat that infection is antibiotics, okay? Yes, it's the broad spectrum antibiotics, okay? Oftentimes it's Zosyn that you're giving. Those are the broad spectrum while the blood cultures are cooking and they're growing whatever microorganism they have. Whether it's bacterial or fungal, we're trying to figure it out, okay? Does that make sense? You have to have have timely administration of antibiotics. Yes,
So
ma'am.
we take the blood cultures and while, as they're processing, we give broad.
100%. Labs in there, they draw your cultures. You better be right behind them with the antibiotic ready to go, ready to hang. Once those blood cultures are drawn, you hang your antibiotic. Okay, it has to be timely. That needs to be your priority. Okay, you need to draw a lactic to get a baseline, and then, last but not least, you're filling your tank. You're filling your tank. Okay, in order for vasopressors to work, the tank has to be full, especially in sepsis. Okay, in fact, it's going to be, no one put it up there, but that's okay, I'm going to tell you anyways, 30 mLs per kg. 30 mLs per kg. Okay, so if you have someone that's 100 kilograms, how much fluid are you giving them? 30 mLs per kg. Okay, so if it's 30 mLs times 100 kilograms, how much?
300
liters.
3 liters. 3,000, right? 3,000 mLs, that's 3 liters. Okay? And then you're going to re-dry your lactic to see if it's gone down. Okay? If it's gone up, we know that what we're doing is not working and we got to give more fluid. Okay? Why am I drawing a lactic? Why is that the particular lab that we draw that in septic shock? You actually can draw it in all the shocks, but in particular, we use it in septic shock. Yes, to see if we're still in that anaerobic metabolism. Okay, when it's high, we know that we're in that anaerobic metabolism and that the cells are not getting adequate perfusion. Okay? Cells are not getting adequate perfusion because we know that that's the umbrella of shock, right? So again, what's the timing of this, you guys? 3 hours. You're getting a lactic, you're drawing your blood cultures, you're giving broad spectrum antibiotics, right? And then you're administering fluids, 30 mLs per kg, okay?
So
Yes,
we can give the broad spectrum before we get the results back?
Yes.
Or do we wait?
No, because it could be days, you guys. The blood cultures takes days to grow. Sometimes if it's a really prolific or what is it called? Infection, I've had them call me back in 4 hours, like a couple hours, and I'm like, whoa, that's not good. Because that means it grew really fast, okay? So again, but oftentimes blood cultures will at least take a day to 2 days to grow, and you're not waiting to give antibiotics unless you'd like your patient to die. Then you can wait. But you should not wait. Broad spectrum antibiotics, and then once we get the blood cultures, we can make it more specific to that organism. Does that make sense? Okay.
So the blood cultures, can they determine if it is viral or would that be something else?
So yes, they absolutely can. They wouldn't grow anything, and then we would know. And there's other tests that we would do, like we send a respiratory panel, and that can tell us if it's viral. Okay, but we want to eliminate that. We want to eliminate if it's viral or not. Yeah, exactly. Because even if, it's oftentimes what will happen is that in viral, just like, so COVID's a virus, right? So we saw with COVID that it started viral and then it turned into bacteria. And that's very common, right? So yes, you technically can't give any antibiotics for viral, but oftentimes you see, especially with like COVID, it turns into some sort of bacterial situation, okay?
Or there's antivirals.
Exactly, you can absolutely give antivirals as well. Yep, absolutely. Or like flu, you give Tamiflu, 100% yes. But oftentimes it unfortunately turns into some sort of bacterial thing, okay? So we gave the fluid, but we're still low, we're still hypotensive. So what vasopressor do you want to start? Norepinephrine, I love it. First line, norepinephrine. Okay, we're still low. I'm at 25 mics per minute of norepinephrine, and I'm still low. What can I add? We're on Levophen. Norepinephrine is Levophen. What else? Vasopressin, yes, vasopressin. Okay, so I've added vasopressin, and gosh, my map is still 59.58. Is that adequate?
No.
No. So what would I like to add next? I'm tachycardic. Don't be telling me dopamine. What did you say? Okay, but why would I start dobutamine? I could start that. But what's that's gonna help me with? Is that gonna help my pressure?
It's gonna help the heart, pump more.
Okay, sure.
better.
Sure, absolutely. You could absolutely see that. Oftentimes, you can have a positive inotrope if we think that our squeeze of our heart is not effective. Absolutely, you could totally see that. Okay, but even when I started it, and I am helping the heart still squeeze, and I'm still hypotensive. My MAP is still 58. What? Phenylephrine. Yes. Good job. Yeah. This is okay. The names will come. The names will come. So we are now on 3 vasopressors. We're on a positive inotrope. Alex added that to help with our squeeze. I think that's great. Okay. Now, how do I know that all of this is working? How do I know that things are getting better?
Lactic acid.
Lactic acid is lower. I love it. What else? What else do you think? Okay, so but what if I don't have that thing? What is that called? That CCO monitor, continuing cardiac output monitor, to know that my cardiac output is good. What else? What other things can I look at to see that we're on the right track? Things are getting better.
Improvement of symptoms.
Okay, improvement of what? Well, blood pressure. Yes, so I have an adequate map. I have an adequate map. Okay, so my tissue perfusion is improving. My lactic is down, or maybe normal. My MAP is adequate. What do you think my kidneys are going to be doing? Making urine. So those 3 things, right, guys? MAP is great. Urine output is great. Okay. And then what about? Do you think he's going to be confused? No. My LOC is improved. Okay. Those are objective data that's telling me things are going well. They're getting better. Okay. You have to understand the difference. You have to understand what kind of treatment you can expect, okay? Now, if we're talking about preventing sepsis, right, I said all of the people in the hospital are at risk, right? So what kinds of things can we do to prevent sepsis?
Hand hygiene.
Yes, hand hygiene. Washing your hands, using Purell. Hand hygiene is key. I love it. What else? Scrub the hub. Yes. Using aseptic technique. You guys, we have so many CLABSIs in our ICUs right now. We are in big trouble. We are in big trouble. So we have, CLABSIs are central line associated blood infections. Okay, we are causing these infections with our patients. Okay, can you imagine? You're going to the hospital to have one thing fixed, and then you're getting another thing because we're giving it to you. That kind of sucks, right? How you can prevent that, scrub the hub. Okay? What do I mean by scrub the hub? What does that mean? What action are you doing? ASAP, you're scrubbing with alcohol before you hook anything up, whether that's a flush or a line, right? And then you're looking at the dressing and assessing for what? When you're looking at the dressing, what are you assessing for? What are you looking for?
Drainage, redness.
Okay, drainage, sure, redness, clean, dry, and intact. You want your dressings to be clean, dry, and intact. You don't want them falling off. Because if you have a dressing that's not on, do you think that is a conduit to an infection source? 100%. Okay. The thing is that when you can get lines out, you get them out. So when you don't need a central line, you take it out. When you don't need a Foley, you take it out. Yes, I know it's so much easier. Don't get me wrong. I love all the access. I want all the access all the time. I want to have central lines. I want to have A lines. I want to have everything. Okay, yes. Do I want to be getting my patient up 500 times a day? No. But should I? Yes, absolutely, because I'm a good nurse. And I know that Foley catheter is a direct conduit to an infection. It puts them at risk. Okay? So I'm getting out invasive lines to prevent sepsis, okay? I'm using aseptic technique, okay? I'm getting people up to ambulate post-surgery, or any people. I'm getting them up to ambulate. Why is that important? Why should I do that?
It helps with blood flow, it helps.
Okay, okay, I like it, sure. Okay, so it helps prevent, when you say blood flow, what might it help prevent? DVTs, I love it, okay. And then what is it doing in the lungs? When you get someone up to the chair or walk around, atelectasis, yes. So you want to prevent that atelectic pneumonia, right? Because again, all of those things that I just talked about, could they lead to infection? You better believe it. Okay, you better believe it. And then what would I want to do? Do I want to administer enteral feeds, like tube feeds, or TPN? Which is better? Which is better to prevent infection? Tube feeds better. So what I need you guys to hear is that with whatever shock we talk about today, okay, whatever shock we talk about, enteral feeds are king. Enteral feeds, those are tube feeds, are important. Why do you think they're so important? Okay, nutrition. Nutrition is very important to fight any sort of situation. Okay, any sort of infection, give people energy to get well, absolutely, okay? But if you think about what TPN is, total parental nutrition, essentially it's sugar water, okay? So we know that that is something that bacteria loves. They're like, woo, party, okay? That was the best. So again, TPN, that's like, here, let me give you a meal, a Thanksgiving meal, so you can proliferate and grow and take over everything. So TPN is not what you want to give. You want to do enteral feeds. Also, it helps prevent translocation. So it helps maintain the integrity of someone's gut. So if we think about, right, someone that is in shock, the blood flow perfusion is not getting to their GI tract, right? What can happen is there could be what's called translocation of bacteria. So the integrity of the intestines, what happens is that they lose the integrity, meaning that, you know, there's poop in there, right? Like in your colon, there's poop in there. There's bacteria. So that means that they go out into your bloodstream. They go out into your body. Does that make sense? So the integrity, like the tube, right? So here's all the bad stuff. Blah, blah, blah. Here's your poop. Here's all the bad bacteria, okay? When you have hypoperfusion, what happens is the integrity of the intestines, you lose it. So now all these bad things are floating about in your peritoneum, and that can cause bad infections, okay? So by giving someone enteral feeds, tube feeds, you can help maintain the, oh my God, I did it again, you guys. I'm like so strong today. You can maintain the integrity of your intestines and prevent that. Does that make sense? Okay. Any shock, enteral feeds. That's what I want you to think about. Any shock, enteral feeds. No TPN. Choose that on your exam. I'm very sad. Okay? Okay, so questions about management and nursing interventions. Questions about how to prevent sepsis and what you need to do to prevent it. No? You guys good? Okay. Oh my gosh, I'm so sorry. Please forgive me. I keep hitting the mouse.
The gym is paying out.
What do you say?
The gym is paying out.
I know, it's right. It's true. My strength overwhelms me. Just like with this cap, I keep putting it on too tightly.
Professor,
Yeah.
for when you mentioned the signs that show us that the treatment is effective,
Okay.
is there, like we have the signs, but
Okay.
is there any that you would say like this would be like the first thing, like the hallmark, or does it not matter?
No, I think it's just like the signs that we talked about. And then remember, your lactic is going to be normal. If you were to redraw a set of blood cultures, they would also be not grow anything.
Like you wouldn't ask like what's the first thing you would see and list them all?
No.
You're really nice.
So you're gonna have the fever and all of that, right? So those against IRS.
I would ask, you guys listen up, I would ask, how would you assess the tissue perfusion. How would you best assess tissue perfusion? What would be your answer? What would be some of the things? I heard urine output, what else?
It's like the gas.
Okay, if that was an option, sure, what else? I'm talking about like clinical assessment. Possibly, if that was an option, okay, what else? Possibly, okay, what else? Urine output, MAP, right? And then LOC. Please do not pick heart rate. Someone can have the worst tissue perfusion in the world and they will still have a heart rate, okay? If they have a respiratory rate, okay? They can have the worst tissue perfusion and have a respiratory rate, okay? How you can assess if the tissue perfusion is better, I'm talking about in any shock, it's urine output, LOC, improvement, and then an adequate MAP. Okay, those are the objective data. Does that make sense? So you're gonna have a heart rate until you die. You're gonna have a respiratory rate until you die. Okay, but it does not equal tissue perfusion. Okay, urine output, an adequate MAP, and improved LOC, like level of consciousness, their awake alert, those all demonstrate tissue perfusion. Does that make sense? Okay. Okay, let's do this question. Your patient who is post-op from GI surgery is presenting with a temperature of 103.6 degrees Fahrenheit, heart rate of 120, blood pressure of 72 or 42, increased white blood cell count, and respirations of 21. An IV fluid bolus is ordered stat. Which findings below indicate that the patient is progressing to septic shock? Okay, so do we think that a blood pressure of 70/34 after fluid bolus is one of the answers?
Yeah.
Absolutely, right? Septic shock, look at it. We have sepsis plus organ dysfunction and then low blood pressure despite fluids. They said that, right? They gave a fluid bolus, but we're still hypotensive, okay? A serum lactic less than 2. Would that be criteria for septic shock? No, it's increased lactic, right? Less than 2 is normal. Patient needs norepinephrine to maintain a mean arterial pressure greater than 65 despite fluid resuscitation. Yep, those are the 2 things, right? And then CVP of 18. Would we expect a CVP of 18 in this type of patient?
No,
Why?
because it's supposed to be hypotensive, it should be under 2.
So remember, our tank is going to be low with septic shock. Okay, why is someone's tank low in septic shock? What's happening? Yes, they're dilated. So fluid is going into the interstitial space. I know, you're like, man, Professor Bloor, stop talking about pathophys. It's important to understand, okay, because it tells you how your patient is going to present. So in septic shock, all those endotoxins and all that stuff is causing capillary permeability. Things are going where they're not supposed to. So you have lots of fluid. That's why they look so puffy and they're edematous, is because it's going into the interstitial space. So vasculature-wise, the tank is low. Okay, so in septic shock, you must fill the tank. You must fill the tank and then probably start vasopressors. Okay, so here we filled the tank. It's still low, so we're starting norepinephrine, also known as Levophen. Yes?
Did you ever give them albumin to pull that?
Totally. Let's try it. Yeah. But oftentimes, again, the fluid, whether it's NS, LR, isotonic, or albumin, is not going to be enough. But yeah, we can give albumin all the time. I love it. Volume expander. It's liquid gold. Sure. Okay. Oh, questions about that last one? No? You good?
I have a question.
Yes, ma'am.
So when they start on septic shock,
Uh-huh.
will you say that at the beginning, because they're gonna have the fever and all of that, it's gonna be like vasodilation and all that?
Yeah. Mhm.
So will that be considered like the early stage of septic shock, or just focus on?
I'm not going to ask you about, I know what you're getting at. No, I'm not going to ask you about the early stages of sepsis versus the late. Okay. It's just confusing because people get it's just confusing. So I just need you to know this progression. Okay.
And I got it. Yeah.
All right, take like 30 more seconds, guys, and then we'll talk about it. take a break. I know you guys are like, please let us go to the bathroom and get my DoorDash. Although Scarlett was very kind with the bagels. Hopefully that gave you some carbs to get through.
I'm pretty sure I have that.
Honestly, maybe she had sepsis. People eat fish and that's
Alright, let's talk about it, you guys. You're providing care to 4 different patients. You're on PCU. You're trying to live your best life. Who are the patients that are at risk for developing sepsis? So, a 35-year-old female who is hospitalized with renal insufficiency and has a Foley catheter and central line in place. Is this person at risk?
Yeah.
Well, Professor Blair, they're only 35 though. They are not geriatric. Why are they at risk? Foley and a central line. 2 places to get an infection. 2 places, okay? 55-year-old male who is a recent kidney transplant.
Yes.
But we fixed the problem. He doesn't have kidney failure anymore.
But he has surgery open.
Yeah, he had a surgery. And what kinds of drugs is he on? Immunosuppressants. So he is very much at risk, okay? 78-year-old female with diabetes mellitus who is recovering from colon surgery. Why is this person at risk?
Surgery.
Colon surgery and type 2 diabetes. Excellent, good job. 65-year-old male recovering from right lobectomy for treatment of lung cancer. Why is this person at risk?
Same as everyone else.
Same as everyone else. He had surgery, right lobectomy, and then he also has cancer. If you have cancer, do you think your immune system is stellar? No. So all of these things, one can probably predict that everyone has some sort of invasive line, right? Whether it's 2 peripherals, a central line, or what. They're all at risk, you guys. Every single one of those people are at risk for sepsis, okay? How can we prevent it? What's the number one thing that we can do? Hand washing, yes. You better believe it. Okay, let's do this question, then we'll take a break.
Yeah, I guess that makes sense. I mean, usually your blood pressure goes up.
So it's just the grocery serum licensing now, or?
Yeah, because when you have an infection, when you're sick, it's easy to do.
Okay guys, I love this question. Why do I love it? Because you can evaluate what you're doing and if it's working, right? So your patient is receiving aggressive treatment for septic shock. Ooh, aggressive. Which findings demonstrate treatment is not being successful? Okay, so a map of 40, is that demonstrating that we are doing everything we can and we're successful? 1,000,000%, right? Not. We need a map of 65. 65 or above would be telling us that we're doing a fabulous job. What about urine output of 10 mLs over 2 hours? No, we talked about this, right? How do we know that we're getting tissue perfusion? Because that's the problem, right? We have this infection that has caused this shock, right? Septic shock. So we know a map, we know urine output, we're not getting it. We need better urine output because 10 mLs over 2 hours is not adequate. A serum lactic of 15. That seems pretty high.
Yeah.
That is telling us that we are still in anaerobic metabolism. We're still not good. Okay, tissue perfusion is not happening. Yes,
What
ma'am.
should the range be for serum lactate?
What do you mean, what's the range? What's the quick, what, I don't understand.
Like right now it's high.
Sure,
But
less than 2.
Less than 2.
Yeah, you want it less than 2. Is that, I don't think there's a range, but you want it less than 2. So you want it normal, essentially. You want it normal that tells us that we are in the appropriate metabolism. That cellular death, right? Cellular metabolism is not altered, okay? And then the blood glucose of 120, great. We're not hypoglycemic. That has nothing to do with telling us if we're successful or not, okay? and then CVP less than 2. Why is this telling us that I'm not successful? What have I not done if my CVP is 2?
Increase the pressure.
Okay, be careful. What does CVP tell us?
Central volume.
Volume, right? So I would anticipate, yeah, a CVP less than 2 tells me that I have not filled my tank, right? I have not filled my tank. I need to fill my tank for the vasopressors to work. Fill your tank. That's one of the things that I want you to think about when you leave my class. I want you to hear my voice. Fill the tank, okay? So I would anticipate that my CVP would be what? Greater than 2, more normal, high normal, right? How about 7 or 8? Does that make sense? Because that tells me that I filled the tank. Remember, CVP is about volume. Do not forget what we've talked about in these previous classes. Everything builds on it. Okay, I know you don't want to hear that, but that's the truth of the matter. Okay, so you'll still see CVP until we finish and you go to pediatrics. I don't know if you see it there, but probably not. Okay, maybe. I don't know. I don't do peds. It's too scary. The kids are too little. Okay, let's take a break. So it's 12. Yeah, we'll do this the last one when we come back. It's 12:05. Let's come back at 12:15. 10 minutes. Okay, 12:15.